Thanks for joining. I have no relevant disclosures. Some housekeeping notes since the talk is being given online are that we have time for questions at the end. So please hold your questions till then. In the meantime, please mute your microphone. And you're welcome to switch off your camera until the Q&A portion. Shortly after the presentation, I'm going to be posting my full prepared remarks, including citations, at uw.edu/staff/Leifer so that you can take a look at my sources. And this is being recorded, and I hope to post a copy of the video up there as well. Today, I will be speaking about COVID-19. Let me first discuss my background. Beyond caring for patients, my academic interest is in biosecurity, which is the field that deals with global threats to health, including pandemics. This interest was deepened by two experiences in college. I completed Stanford's undergraduate honors program in international security studies, where I learned about global threats. And then during college, I worked at the US Department of State and as the Science Advisory Office's team lead on the H1N1 swine flu pandemic when it first emerged. I was inspired to work on medicine and public health and went to med school at UC Davis. During med school, I rotated through the CDC's flu division and was deployed to Missouri on a disease outbreak investigation along the officers in the CDC's Epidemic Intelligence Service. Then during pediatrics residency at Northwestern, I did a part-time fellowship in biosecurity at the Johns Hopkins Center for Health Security, which is the hub of the field. Afterwards, I applied for derm residency. And during the interview day, Dr. Neum, Dr. Colvin, and Dr. Sidbury made clear that if I came here, they would support my biosecurity pursuits. And the program has certainly done that. Last year, the program sent me to the East Coast to do a week-long medical course with the US Army about how to care for patients during chemical and biological attacks. It was an awesome experience. Combating pandemics has been one of my long-standing interests and passions, and unfortunately, now my training is relevant. What I would like to provide with this Grand Rounds talk is context around this pandemic. I'm going to walk you through the fundamentals of epidemiology for this pandemic, especially the reproduction rate and the epidemic curve. I will walk through different options that we can take in King County in fighting this pandemic, drawing heavily on other countries' experiences. And lastly, I will review the urgent scientific questions that we need to answer and what those early answers are shaping up to be. So a helpful lens for looking at any pandemic, including this one, is through the the reproduction rate and the epidemic curve. The reproduction rate is one of the fundamental figures in an outbreak. It's the basic reproduction rate is called R0. R0 is defined as the expected number of secondary cases that result from a primary case in a population that has no immunity. Put another way, it is the average number of people that an infected person will go on to infect in a susceptible population. R0 refers to a population that has no immunity, and that means a vaccine does not change R0, and also means that population immunity does not change R0. The best estimates give COVID-19 an R0 of around 2.5, and that means that before social distancing, each infected person went on to spread COVID-19 to about 2.5 people. On average, about half of those transmissions come before the infected person ever shows any symptoms. R0 can be changed by environmental factors and by behaviors, and we've seen this with COVID-19. Currently, across Washington state as a whole, R0 is approximately 1 because of social distancing. Now, closely related to R0 is R sub E, or R, which is the effective reproduction rate. This is the true reproduction rate in the population, accounting not just for environmental factors and for behaviors, but also for immunity. right now, there isn't really a distinction between R naught and R because so few people in the population have COVID. Once we have a COVID vaccine, R is going to drop tremendously because it accounts for immunity, but R naught will be the same. I'm just going to re-summarize this because it's really crucial to what follows. R naught is the expected number of cases that an infected person will pass the disease on to in a population that is completely susceptible. R, or R sub E, is the actual number of cases that that infected person will pass it to, and that is influenced by immunity as well as the factors that guide R naught. In an outbreak, if R is greater than 1, the outbreak will tend to worsen over time. When R is less than 1, the outbreak will tend to resolve over time. And so now that we've learned the concept of the reproduction rate, let's look at our local epidemic curve here in King County. I've been compiling this chart every day since March. You'll note that it only goes to about April 22nd, and that's because the data aren't as accurate for recent days. The chart is displayed in a very particular way. It is a logarithmic plot, and that's ideal for exponential processes because it shows them as a straight line. Also, each data point is the 7-day rolling average, and that's intentional because disease reports aren't reliable over the weekend, and so it smooths out the curve for greater readability. Now, I've added here the dates that the county and the state took action. On March 17th, restaurants were closed. And then on March 23rd was Governor Inslee's stay-at-home order. What you see is a very steep initial rise in cases, followed by a gentle decline starting a couple weeks after social distancing was implemented. Now, during the first part of the outbreak, before social distancing, R was greater than 1, and the number of daily cases shot up with an initial doubling time that I calculated of every 4 days. And if you look at the last week, R has been slightly less than 1. And during that recent decline, the case number has dropped by half every 34 days. And therein lies one of the main issues with this outbreak. The count surges up quickly, but then takes a long time to go back down. There's something else interesting about the curve too, which is that it takes about 2 to 3 weeks after social distancing is imposed for the epidemic curve to show an effect. So why the delay? It's because it takes time for people to acquire illness, show symptoms, present to care, receive a swab, get the test result, and then have the public health department report the results. This is an important point, and we're going to revisit it shortly. Let's also take a look at the death curve. The death curve is a lagging indicator behind the case curve because there usually are many days between a patient having a positive COVID test and they're dying of the disease. And here on a combined graph showing both the case count and the death curve, you can see that. The peak in the death curve is 6 days after the peak in the case curve. Still, the death curve is an undercount, and we are finding in many cities around the world that more patients than the graphs would reveal are dying of COVID. This is because some people die at home of COVID and are never tested for it. And also, some patients with myocardial infarction or stroke or other conditions never present to hospital because they're afraid to go to the emergency room. And so it's enlightening to look at excess mortality data by looking at what the baseline is of deaths in the population and then looking at the increase relative to baseline. Here's a graph from the New York Times, and it shows that there have been at least 20,800 excess deaths through April 25th. I calculate that as at least 1 out of every 411 New York City residents who have died because of the virus. We'll look at one more epidemic curve. This one again is from the New York Times. On the left is a curve of the New York City metropolitan area, And on the right are US cases excluding the New York City metropolitan area. Note that it's a linear plot, unlike the log plot that I showed you before. If you exclude New York City in the US, R naught is currently greater than 1. And you can see that with the case count going up. Currently, states and counties can decide between 3 options. And that is, there we go. That is an R that is greater than 1, an R that approximates 1, or an R that is less than 1. Let's start with the first option of weaker social distancing and R greater than 1. The experience of the Hokkaido province in Japan, which tried loosening its restrictions in March, is instructive. It decided, so it had good initial control of the virus and decided to relax its strict social distancing and reopen schools and tourist areas. Within 26 days, cases had exploded and controls were reimposed. And that it took 26 days is not a coincidence. Remember from the Seattle curve that it takes about 2 to 3 weeks for a change in social distancing to influence the epidemic curve. Now, currently, many states around the country are reopening, most notably Georgia. And Georgia is going to have things play out in a predictable way. About 3 weeks after reopening, the daily case count will have accelerated exponentially, and the governor is going to be forced to reimpose social distancing. But there is going to be a lag. Once social distancing is reimposed, it's going to take about another 2 weeks for that intervention to show an effect, because some people will have already been exposed to the virus but are not yet showing symptoms. And until social distancing kicks in, Georgians may be forced to watch helplessly while hospitals are increasingly overwhelmed and the death count mounts. What makes the situation especially dangerous for Georgia and for us if we were to attempt reopening is that the more generations you are into exponential growth, the bigger the growth becomes in terms of absolute numbers. Here's one way that helps me visualize this. Georgia was at about 600 newly identified cases of COVID-19 per day prior to their lifting their restrictions. Austria has a similar population, and at that time had about 70 newly identified cases of COVID per day. Austria is not lifting its restrictions, but Georgia is. And let's imagine that both of them relaxed their social distancing for 4 weeks and then re-implemented controls after cases surged. Using a conservative estimate that the doubling time is about every 7 days, at the end of 4 weeks or 4 doubling times, Georgia would have gone from 600 to 9,600 cases per day, and Austria would have gone from 70 to 1,120 cases per day. For Georgia, that is a net increase of 9,000 cases per day, and for Austria, it's a net increase of 1,050 cases per day. Georgia's hospitals can barely keep up with demand as is, and that high a number would be a tsunami of patients. The point here is that loosening restrictions when the case count is already high is extremely risky because it takes an already large number and subjects it to exponential growth. And then what happens when Georgia reimposes its restrictions? Then it's going to take a very long time to get the daily case count back to where it was, because Georgia and the US as a whole have not been able to get the value of R significantly below 1. So the likely outcome is a surge in cases followed by a lengthy plateau once controls are put back on. Unfortunately, the US is in a pickle, just like Georgia is. We are a significant outlier compared to the rest of the world. Each day, as this chart shows, over a third of the total COVID deaths worldwide are in the US. Countries in much better shape than us are not contemplating reopening movie theaters and hair salons. And shockingly, COVID is currently the leading cause of death nationwide in the US. We need our case counts much, much lower before it's safe to reopen. And several states have jumped the gun, and it may set the whole country back. So what if we say, let's go back to normal life and just wait until there's herd immunity? A figure that you might have come across is that once 60% of the population is infected, we'll hit the herd immunity threshold. Now, this is true, and you can actually calculate this yourself using R naught. The herd immunity threshold is defined as R naught minus 1 all over R naught. But importantly, this herd immunity threshold is the threshold where R finally becomes less than 1. That means that 60% isn't the point where the outbreak vanishes, it's just the point where it finally begins to slow down. Far more people than 60% would continue to get sick, and it's a fair estimate that fully 80% of the population would ultimately become infected by COVID before it could be fully suppressed through herd immunity. Even then, the disease would be endemic, and because of new people being born and existing people dying, it would sporadically flare until there was a vaccine. Now, all of this is assuming that all recovered patients have lasting immunity to COVID, and we don't know that. Simply put, having a reproductive rate greater than 1, even for a brief period, isn't sustainable and leads to an unconscionable number of deaths. States and countries that have tried having an R above 1 have paid a terrible price before being forced to change course. And each brief increase in cases takes a lengthy period of social distancing to undo. My thought is that while it is difficult being under siege, opening up the gates and letting the virus in can be worse. So the second option of loosening controls so that R remains around 1 means a controlled burn, potentially for years until we have a vaccine. Most of the economy would have to remain shuttered to maintain that R value, and each day would bring about the same number of new cases and deaths. With this, there's an equity issue as well, because those who are having to work in jobs that require in-person interaction would be at significantly higher risk than those in jobs that can be done from home. And so that leaves just one more option, and that is to get R to less than 1 with the possibility of fully eliminating the disease. That's the option that I and the public health community favor, and it's absolutely possible to get R to less than 1, and in the long run, it's cheaper than the alternatives. King County is doing it currently, and several countries are doing it more successfully than we are. Let's look at how. The 5 main measures that have successfully decreased R worldwide are social distancing, contact tracing, isolation, and interventions in congregate areas. So the first is social distancing, and I'm going to skip that because we are all familiar with social distancing. Testing for active infections is crucial. For testing to be effective, it should be free, widely accessible, easily administered, accurate, and fast. We're not there yet. There is some progress. There are rapid tests. Some of the best ones have a 45-minute turnaround. Rutgers University has developed a saliva-based test. It's not rapid, but it can be self-administered, and it obviates the need for a swab. Some countries are implementing universal testing at nursing homes, and our hospital is screening all preoperative patients and all newly admitted inpatients. Although there are strides, there is universal agreement among the public health community that we remain far behind. Next is contact tracing, which is a mainstay of pandemic response. About half of transmissions from COVID-19 happen before an infected person shows symptoms, and an unknown number of patients never show symptoms. Picking up asymptomatic and pre-symptomatic patients requires contact tracing. In it, teams of investigators contact a patient immediately after a positive test results. They investigate who they came into contact with, and they notify those contacts to self-isolate. Often those contacts are monitored or tested during the 14-day period that follows the possible exposure. Something that complicates contact tracing for COVID in particular is that it has to happen very fast. There might only be a day or two between the time a patient has a positive test and the time that one of their contacts first starts infecting others. The US would need a very large workforce of contact tracers, and estimates from the Johns Hopkins Center and also the group that coordinates state public health officers make estimates that range from 100,000 to 300,000 workers who would be needed worldwide at the cost of several $billion. This is a tall order, although conveniently, there is a large and growing pool of skilled and motivated workers who would be happy to have work if only the federal government would fund it. Countries are being creative about who they tap for contact tracers. Some countries are using their police detectives and the military to track down cases. And in the US, we're seeing some creativity as well. Anne Arundel County in Maryland, which has Annapolis, is staffing its contact tracing team with its school nurses because they're no longer working while schools are shut down. Some public health departments are recruiting medical students as well. Technology can help contact tracing investigations, although there are considerable privacy concerns. Several countries, including South Korea and Norway, have an app for smartphones that logs every phone that your own phone comes in close proximity to. And then when a patient tests positive, it notifies all of the phones that have been in contact. Contact tracers in Singapore use surveillance video as well. Now, while the cost of contact tracing is high, it pays itself off many times over. And as the number of cases goes down, the number of contact tracers needed goes down with it. A big advantage of contact tracing is that unlike social distancing, which is a blunt instrument, contact tracing is a very precise tool. It focuses its resources exclusively on those with the disease and those who are exposed. Another pillar of pandemic response is isolation capacity. If a patient is symptomatic, or if they've come in contact with a sick person, they need to have a place, they need to be isolated. And so having sick leave is very important for that reason. If staying home means losing a paycheck, then symptomatic workers are more likely to still show up to work. Offering bonuses based on attendance is also a mistake. The Smithfield meatpacking plant in Sioux Falls, South Dakota, as reported by the Sioux Falls Argus Leader, is home to one of the largest outbreaks in the country, and it offered its employees a $500 responsibility bonus so long as they didn't miss a single shift during the month of April. Here in the US, we also need isolation facilities. If a patient tests positive and recovers at home, they may well infect some of their household contacts. Better is to have at least the option of a site where patients can recover without the risk of infecting others. And to King County's credit, we do have a motel that can operate with that function. In South Korea, according to a neat ABC News story that detailed their response, patients who test positive but are either asymptomatic or mildly ill are offered a place in a designated quarantine facility for 2 weeks. Whether they stay in the quarantine facility or at home, they receive a personal necessity kit that includes gloves, masks, garbage bags, soap, and thermometers, as well as enough food to last for 2 weeks, including some pre-made meals. In some cases, those who are on quarantine are given a salary. And again, although this is costly too, there is a significant payoff. And South Korea on May 3rd reported its first day with no new COVID cases. Contact tracing helps to identify hotspots. And during this outbreak, as with most respiratory outbreaks, that is in congregate settings. The largest outbreaks in the US have generally been in factories, prisons, nursing homes, and cruise ships. And other areas of concern include so-called essential businesses, including medical facilities and grocery stores. By identifying hotspots, the public health department can monitor those sites more closely and modify them to make them safer. You'll notice that the 5 items that I discussed, social distancing, testing, contact tracing, isolation, and snuffing out hotspots, tend to reinforce each other. To do contact tracing, you need testing. To help the patients who you contact trace, you need isolation, and so on. And so you might ask, if we just had excellent testing and excellent contact tracing, could we just go back to normal? The example of Singapore suggests that we can't, and that normalcy is not going to be possible unless there's a vaccine or unless we eradicate the disease. Singapore is an island nation with what is considered one of the best contact tracing systems in the world. They're also highly centralized, and they're a fairly autocratic state with robust surveillance systems. You can see from the surveillance curve that it initially had the outbreak under control. And unfortunately, though, the case count erupted, and it's having to work now to get that outbreak under control. Given that the world's best contact tracers couldn't control COVID-19, it's unlikely that contact tracing and testing alone are enough to allow a return to fully normal. I take this to mean that social distancing in some form is likely to be our new normal until there's a vaccine, or until the virus is eliminated within national borders. Mass gatherings like sports events and concerts are probably not going to be workable before then. But you can get closer to normal, and it involves using the measures I discussed that bring down R0. Several countries have managed to get R0 quite low. This is a great chart. It's put out by the Financial Times, and it compares the daily case counts in multiple countries when they were at similar stages of their outbreak. Again, a positive slope correlates to an R greater than 1, and a negative slope correlates to an R less than 1. Look at the countries towards the bottom of the y-axis. Ireland, Australia, New Zealand, South Korea, and even China are close to eliminating the virus completely. Other countries aren't far behind, like Ireland, Australia, Norway, and Greece, who've all managed to get their curves pointed far down. And then, although not on this chart, Hong Kong and Iceland deserve special mention as well. The advantage of getting R0 down, as many countries have, is that it gives you wiggle room to then ease some restrictions while still keeping R0 substantially below 1. What you give back depends on your priorities. Would it be to reopen school, or to have elective medical procedures, or to allow for funerals? You can try these things, and if R0 starts to creep too high, then some of those controls can be reimposed. Right now, though, King County doesn't have room to go up because we've not managed to get R0 substantially below 1. In the meantime, according to much of the public health community, it will not be safe to partially reopen a place until all of the following criteria are met: low case numbers, an R below 1, robust testing capacity, contact tracing of all cases, and good hospital capacity and PPE supply. Also bear in mind that after loosening, it takes at least 2 to 3 weeks to know whether you've overshot the mark and need to reimpose controls. I want to underscore that it is absolutely possible to reduce cases and even eliminate this virus within our borders if we made that our national goal. So far, that is not the goal, and the mind-bogglingly inept and corrupt response of the federal government, and especially the executive branch leadership, is actively undermining the fight against the disease. There's only so much that states and municipalities can do to fight a pandemic without having federal assistance and without a coordinated federal response. And since Seattle is connected to the rest of the country, it's not going to be possible to snuff out the infection in Seattle so long as the virus is raging through other parts of the country. The absence of coordinated response has and will continue to exact a terrible toll in economic damage and in lives. We as physicians can at least lead by example by strictly adhering to social distancing ourselves, by making it so that our clinics are not places where virus can spread, by isolating ourselves when we are symptomatic, and by performing our own contact tracing when one of us becomes ill. We also can do our part to provide those around us with accurate information about the virus. And now I'm going to shift gears to discuss some of the most urgent questions that need to be answered during this pandemic. And I'll discuss where we are with answering those questions. First, as far as treatments and specifically medications, the hunt for medications to treat COVID includes identifying existing medications that could treat it and also develop new medications. As far as existing medications, The NIH is performing a randomized controlled trial with the antiviral remdesivir. Partway through the study, they announced preliminary findings last week that patients on the medication had a statistically significant reduction in the length of their hospital stay. They did not have a statistically significant reduction in mortality. I also list here several other medications that have been studied, and they were found to either offer no benefit or to cause harm. There are new candidate medications in various stages of development, and I don't know their particular timelines or their likelihood of success. I'm not holding my breath for a miracle drug. I think a vaccine is a more fruitful and likely game changer for the outbreak. Convalescent anti-serum is an old-fashioned study that's being used and is being studied. And this goes all the way back to the early 1900s. Simon Flexner, who is not the Flexner who did the Flexner report, successfully treated meningococcus using intrathecal equine-derived anti-serum. And this was the standard of care for decades and worked quite well. And then it was replaced by sulfonamide antibiotics in the 1930s. Animal-derived anti-sera can treat several viral infections, including polio, measles, mumps, and the flu. The approach with COVID is to use convalescent serum donated by recovered COVID patients. The approach is rather safe so long as the blood's carefully screened, although it's worth noting that there's one potential downside in that when you give exogenous antibodies, it can suppress a patient's immune reaction. This is what we see with IVIG injections, and that could impair the patient's development of immunity to the virus. The use of convalescent serum is being studied currently in multiple randomized controlled trials worldwide. And another approach that's in development is to generate monoclonal antibodies that neutralize the virus. With vaccines, vaccination has two parts. There's passive vaccination, there's active vaccination. If either convalescent serum or monoclonal antibodies do prove effective, they could be used as passive vaccination. And in this way, exposed contacts could receive antibodies, similar to what we do now with rabies prophylaxis or with Hep B prophylaxis after a needle stick. With sufficient capacity, it could also be used to temporarily immunize those at elevated risk, like the elderly or frontline workers. But the game changer that we need is active vaccination. The most recent estimate I saw is that there are 90 COVID vaccines in various stages of development. While some are promising, we need to keep some things in mind. First, vaccines tend to take several years to develop, and most are unsuccessful. While the hope is that we can dramatically speed up that timeline, some parts just can't be sped up. And the fastest that we have ever developed a new vaccine was the mumps vaccine in the 60s, which took 4 years from the viral samples being obtained to the vaccine being created and declared safe and effective. With vaccine development, there are some ethical issues. The most direct way to test a vaccine's efficacy is to intentionally infect the recipient of the vaccine with the virus, which is called a human challenge trial. And that's how Edward Jenner first demonstrated the effectiveness of the smallpox vaccine. He immunized an 8-year-old boy and then exposed him to the smallpox virus. Human challenge trials are considered unethical, and Jenner's experiment has not aged well. But interestingly, thousands of people worldwide have volunteered to undergo challenge trials at significant risk to themselves if it would help to speed the development of a COVID vaccine. The question is it ethical to let them? Also, our vaccine manufacturing capacity and the vaccine manufacturing capacity of the world is nowhere near what we would need to manufacture doses of the virus for the country. And if we wait until the virus is approved and cleared, there are going to be valuable months or years lost. There's a major equality issue as well, because rich countries shouldn't be the first to receive a vaccine while the rest of the world is left exposed. The Gates Foundation is being quite proactive, and it's committing funding to set up factories to manufacture the most promising vaccines that are under development. That way, there will be doses on hand should any of those vaccines turn out. We need more actions like this that anticipate the rollout of a vaccine. And even though there will inevitably be some waste and there will be vaccine doses made that we can never use, it will pay itself off several times over. Our country might not have an easy time accessing whatever vaccines ultimately developed if we're not the ones who develop it. Not only did the Trump administration recently announce that it was withholding funding to the WHO, it poignantly refused to join a multinational initiative to develop a global vaccine. If that initiative does develop the winning vaccine, the US could be the last in line to get it since it refused to contribute. As far as respiratory support, interestingly, COVID affects primarily oxygenation and not ventilation, which is the outgassing of CO2. Hypoxemic COVID patients aren't short of breath, and that's because CO2 levels are normal, and it's the CO2 that is responsible for respiratory drive. Because there's only a need for oxygenation, it's less important to intubate patients, and that leaves more of a role for non-invasive breathing methods like CPAP or BiPAP or high flow nasal cannula. One issue with those non-invasive breathing methods, though, is that they aerosolize viral particles, increasing the risk to providers. And also CPAP and BiPAP require expensive and specialized equipment and specially fitted masks. And so one solution that has been developed before, but now is being used at some hospitals, is the breathing helmet. And this is a photo from University of Chicago Medical Center, and they're one of the hospitals that's using it. They're relatively inexpensive to manufacture and operate, and they plug straight into the wall oxygen supply. A big advantage is that they don't spray aerosols into the room because the exhaust is hooked up to a HEPA filter. Next is modes of transmission. When people sneeze, cough, or breathe, they generate droplets of various sizes. Those liquid droplets that are less than 5 microns in diameter are aerosols, and those airborne particles penetrate more deeply into the lungs and are not filtered out by surgical masks. Now, SARS and MERS are coronaviruses similar to COVID-19 and may require airborne precautions because of aerosols. And while the WHO came out early and put out infection control guidelines that assume droplet transmission, I've been watching the literature with interest because I've suspected that COVID would probably have an element of aerosolized spread like its coronavirus brethren. In the peer-reviewed literature, there's a paper in the Annals of Internal Medicine that found that cloth and surgical masks are ineffective at stopping the release of virus in coughing patients who are COVID positive. There's an interesting accepted manuscript in Nature. This is a team in Wuhan who sampled particles in various parts to hospitals looking for aerosols, and they found virus-laden aerosol particles in multiple parts of the hospital that weren't near patient rooms, including bathrooms, changing rooms, air ducts, and a supply room. The team's findings matched those published in a preprint out of University of Nebraska, which detected viral-laden aerosol particles in the hallways of the hospital outside patient rooms. These studies confirm the presence of aerosolized droplets that contain the virus, but it doesn't answer the key question of is there sufficient inoculum of virus that someone inhaling those particles would be at risk of contracting it. There is a preprint that suggests aerosolized spread. Preprint means it hasn't been peer reviewed, but this is such a beautiful study that I'm going to show it anyway. It's from epidemiologists at the University of Georgia, and it's just a beautiful field study from an outbreak in China. The story is that a group of Buddhists went to a worship ceremony at a temple. Some went by bus, and in fact they had 2 buses, and that's important. The passengers all stayed in the same seats during the 50-minute ride there and the 50-minute ride back, and the event at the Buddhist temple was 2.5 hours long. This diagram here shows where the passengers sat on that bus that had the COVID patient. It's hard to see, but the index patient is in row 8, and all of the seats that are red, yellow, or green are people who contracted the virus. In all, the attack rate was 34% among passengers on the involved bus. It was only 3% among those who attended the ceremony at the temple without taking the bus, and 0 passengers on the other bus contracted the virus. It's a very elegant piece because it gives strong evidence that the virus was spread on the bus, and it spread all over the bus. The authors suggested that the air conditioning on the bus had a role. There's also a paper in Emerging Infectious Diseases. There we go. This is a restaurant in China, and the authors concluded that the restaurant's air conditioning system had spread the virus away from the index patient, who's seen in yellow, to the infected patients in the room, and those are the red circles. Those authors did not see it as evidence that there's aerosolized spread, but it does call into question whether the conventional wisdom of 6 feet separation is adequate when you're in a ventilated enclosed space. Currently, all of our clinical sites have mandated that we have universal masking in clinical spaces, but it's not, it is unclear to me as to why we're using surgical masks when the evidence for airborne spread's unsettled. My thought is that if you're going to wear a mask anyway, why not wear an N95 rated mask that covers all of your bases? The ADA, the American Dental Association, recommends that dentists wear them when seeing patients. And in my view, the ADA's anagrammatic relative, the AAD, should have the similar recommendation. It's true that we have limited supplies of masks and of PAPRs. And to me, that's a sign that we shouldn't be depending on disposable masks, especially since there's a shortage. Our hospital is even trying to reuse N95 masks by treating them with UV radiation. If the masks are meant to be disposable, why try to reuse them? If you know me, you'll know that I am a big proponent of elastomeric respirators, which are truly reusable respirators. They filter particles better than N95. They fit more people, they don't fog up, and they're more environmentally friendly because they're reusable. They're FDA approved, and for decades, some hospitals in the US, including University of Maryland Medical Center, have used them in place of disposable respirators. I wear my respirator anytime I'm in public in an enclosed space, and I think that as dermatologists, wearing a respirator makes intuitive sense because it's like sunscreen for the lungs. You put it on each morning, you leave it on during the day, and even though it looks funny and people might tease you about it, it helps you stay out of trouble down the line. They cost about as much as a bottle of high-end sunscreen, and so while I would say I'm putting my money where my mouth is, the respirator doesn't cost that much, so I'm really just putting a bit of money where my mouth is. Unless the science changes, I'm going to be wearing a respirator when I see patients. I encourage you all to join. Regarding immunity, we do not know if those who recover from the virus have immunity. So far, there's not been a report of reinfection with COVID-19 that has survived subsequent scrutiny, and that's a hopeful sign. One way of making sure is by looking at the genetic sequence of the original specimen, and then there's a report of a positive test in someone who had previous infection. You can look at that genetic signature of the new virus and see if it's the same or different. So far, it's been the same. There have been a number of serology tests that have come online, and UW's offering theirs for free through Employee Health. Serology tests are a great public health and research tool, but currently they don't have clinical utility. We don't know which antibodies prevent infection, and we can't interpret the results. Now we move into some things where there aren't great answers. One is children. For reasons that aren't understood, children are less susceptible to COVID-19, and they have considerably lower morbidity and mortality. It's also known that infected children have high levels of virus and that they shed the virus in their stool. The major question is, how readily do infected children transmit the virus to other children or to adults? It's important to find out because it's going to be difficult for parents to return to the workforce without reopening daycares and schools. As far as long-term sequelae, we don't know if this virus has delayed effects. You can think of measles, for example, which has a devastating encephalopathy that happens decades later. It's worrisome that COVID affects so many organs, the lungs, the heart, the liver, the kidney, the vasculature. And while there's reason to worry about lasting effects, we don't know, and all we have is anecdote. It's going to be difficult to quantify the risk of being infected until months to years pass. The one pertinent study I could find on this topic was in The Lancet. It found that a majority of asymptomatic COVID patients imaged had ground glass opacities on CT imaging. It didn't follow up on the patients. And then relevant to us is what are the risk factors of infection? And are there particular immunosuppressant agents that we should optimally have our patients on? I'm not aware of any answers, and I'm not aware of any studies. As I wrap up, I want to share a few observations as a longtime student of pandemics, which I'm using to help guide me through this pandemic. First is that during a pandemic, healthcare workers are especially valuable and especially vulnerable. We have a very specialized and important skill set, and it takes years to train a replacement. There's demand on us all the time. There's especially demand during a pandemic. In every pandemic of a respiratory disease, including this one, healthcare workers have a considerably higher rate of infection than the rest of the population. UW is no exception. As of Monday, 222 medical staff have tested positive for active COVID infection at UW Employee Health. This outbreak could last years, and I think we'd be wise to play the long game and do everything we can to minimize our risk. Hopeful thinking is good and wishful thinking is not. We need to face problems head on without minimizing them. We also need our optimism and good spirits to carry us through. While pandemics are biological, the response is political. I'm reminded of Virchow, who said that medicine is a social science and that politics is nothing else but medicine on a large scale. That's especially true in a pandemic. It's our policies that are going to determine how successful we are at dealing with this pandemic and how equitably its burden is shared among the populace. The virus sets the timeline. We're understandably getting impatient with social distancing, and it's frustrating that while we act, our federal government continues to dawdle. That said, the virus doesn't care how we feel. The virus sets the timeline, and like it or not, we have to respond on the virus's terms. And lastly, memories are short. Our public health system is perpetually underfunded, and people don't pay much attention to it between crises. I hope we'll have a longer memory and that we'll invest in our public health and healthcare infrastructure between crises. I have just a few more points. Here are some places where you can find epidemic curves. Outbreak.info is a neat website. The Financial Times is the graph that I showed you. I have a Twitter account with the King County epidemic curves because I couldn't find good data and decided to just make it myself. Please use caution with the IHME model. It uses a flawed method that is not epidemiologically sound. It's had inaccurate forecasts, and while I'd love to support it because it's a UW institution, the epidemiology community really thinks it's discredited. Where I like to find my COVID info, the Johns Hopkins Center for Health Security has a newsletter and a number of white papers coming out all the time if you're interested. Here are some other sources, and I'd point out the Epidemic Intelligence Service. This is a 2-year elite program that trains mostly doctors how to respond to disease outbreaks. And there are a number of highly trained alumni who are on our faculty. It turns out that we have one on our derm faculty. Dr. Tapero, who just joined us, is an alum of the program. Also, Dr. Dushin, if I'm saying that right, our county health officer did the program, our state health officer did. If they have thoughts on pandemics, I would listen. And then I'm partial to alumni of my fellowship program. If you are interested in studying biosecurity as part of a part-time fellowship, please talk to me so I can tell you more about it. I have lots of people to acknowledge. I especially want to thank my program, the faculty, my mentors, my co-residents, the staff, the Johns Hopkins Center, and to the many friends and family members who are tuning in. I saw one of my PEDS co-residents from Chicago tuning in, thank you. And my family is watching from Colorado and New Jersey, and my girlfriend Rachel is watching from Vancouver, BC. So again, my prepared remarks are going to be up online at this website. And with that, I would like to turn it over to questions. Thanks so much for your attention.
Thanks. Thank you so much, Dan. Yeah, so let's start. Dr. Moshiri, do you want to offer up your question that you asked earlier?
Yeah, okay. Oh, well, I see it in the chat. How about I try to just
perfect.
plunge through. Okay, what is the R naught of influenza. And just so people who see that know, it's not is spelled a bit differently. But what is this value relevant to discussing the comparison between COVID-19 and the flu? So R naught of flu is around 2, 1.5 to 2. And is the value relevant? Yeah, I don't totally know how, but let's say it's similar to flu. And the playbook for how to treat pandemic flu is really relevant to the playbook for COVID because it has a similar R naught and it spreads in a similar way. Assuming we lived in a population that is planning on reopening prematurely, what can we do as individuals and groups to minimize risk of exposure? It's to practice social distancing yourself. Dr. Shinohara, can you discuss your take on Sweden versus Denmark? From what I know, Sweden is trying to attain social distance or attain herd immunity, which, as I said before, I don't think is a good goal. As far as, I don't know much about the two countries though, so I'm going to punt. Dr. Wang, how do you effectively carry out contact tracing and isolation if 50 to 90% of tested positive individuals are asymptomatic? Well, the asymptomatic people may well or probably have caught it from people who are symptomatic. So if you can detect the symptomatic patients and figure out who they came into contact with, you can have the asymptomatic patients isolate because you know that they're a contact. So that contact tracing is really the only way to get after the asymptomatic patients unless you're doing widespread testing. Dr. Liu, which of the 5 methods did South Korea implement? All of them. They did all of them and it worked. Dr. Fleckman, if the virus mutates as influenza, will vaccines have to adapt? Will this be more difficult with R naught greater than 1? That's a great question. Coronavirus could well mutate. The common cold does that. And yes, that's going to be really difficult. Dr. Shinohara says, if we can't, why can't we use the example of the development of the yearly influenza vaccination as a model for this vaccine rather than mumps? Yeah, so the flu vaccine doesn't have to go through phase 1, phase 2, phase 3 trials. The shifts to the vaccine are so minor that it's essentially the same vaccine and doesn't have to be tested for safety. The coronavirus is essentially a brand new vaccine, so it has to be done from scratch. So it is the same example. The yearly influenza vaccine is a good example. If you are thinking of the first flu vaccine that was developed. Doesn't the low rate of infections within healthcare workers suggest that airborne infection is rare to non-existent in this setting? I don't see the rate of infections among healthcare workers being low. The IDSA just put out some guidelines that says that the rate is 3 times higher than the rest of the population. Among healthcare workers. So yeah, I also did some math calculating of those 220, if we take the number of employees who tested positive and the number of UW employees total, are they overrepresentative relative to the rest of the population? And I found that yes, they are. I don't recognize this name, I'm sorry, but I'm going to say it's Dr. Spounhurst. What criteria does a good elastomeric respirator need to meet? A P100 rating, are there other specific ratings we should look for? That's a great question. So if it has a number that is 95 or greater, you are good. That letter in front refers to different, for example, oils or organic vapors that it can filter out, and it doesn't really matter what the letter is in front. And so the 95 and N95 refers to how good it is at filtering out small particles. If you have a number that's 95 or greater, you're fine. A good elastomeric respirator should fit, and you should undergo fit testing to make sure it fits. Dr. Neum, can you please be specific about why the IHME model is flawed? Yes, absolutely. The IHME model it has changed a bit because it hasn't worked well. But what it has done is it takes a bell curve, which is it's a kind of curve that has a symmetrical rise and fall, and it just takes the deaths so far and just tries to stick a bell curve into that. And so if you remember what the epidemic curve looked like, it has a really steep rise and then a very slow tail. But the IHME model is entirely premised on having an extremely steep decline, as steep as the rise. It doesn't make any sense, and it has no knowledge of R0 or how the virus transmits. All it does is just fit a curve to the existing data, and that doesn't work. So there is a different type of model called SEIR, S-E-I-R, that works much better. And the IHME model is a favorite of the White House because it so consistently underpredicts the number of deaths, but it's just inaccurate. And I wish they would get out of the business of forecasting this pandemic. How reliable are current screening tests in Seattle and elsewhere? I don't know the answer to that. Happy National Nurses Day. Okay, last question, it looks like, from Dr. Berg. What do we think of the polyclinics experience that none of the MDs that are in the respiratory clinic have been infected over 6 weeks, and that's using just surgical masks. And we've talked offline about this too. I think that's great. I still don't feel comfortable discounting the risk of aerosolized spread, given the evidence out there and the experience of other coronaviruses. Hopefully there will be more evidence and it will be more rigorously studied, but we don't know. My take is when you can't quantify risks, if it's easy to mitigate that risk, go for it. So if it means just wearing an N95 instead of a surgical mask, I feel like that's worth it. But certainly I'm keeping my eye on what the science shows and what we find from studies. I am 3 minutes over time. Happy to talk to any of you afterwards. Thanks so much for being here. Really appreciate it.